May underway. My name is Andrew Stevenson. I'm chair of the Trust. Can I start this meeting by welcoming our new Chief Exec, Steve Williamson, on his first public board meeting on day 7 or day 8, something like that, in the organisation. So welcome, Steve. Can I also note that this is Helen Cobb's last board meeting before her early retirement on the 23rd of June. So can I put on record my thanks to Helen? It's been a pleasure working with you, and thanks for your many, many years of service to both this trust and the wider NHS. So thank you. Are there, apologies of interest at the start of this meeting? I have received apologies for absence from Carrie Cobb, Colin Forrest, Nicola Hayward-Cleverly and Brian Webster Henderson. Are there any other apologies for absence? If not, declarations of interest have been circulated. Are there any changes to those? Amin?
Yes, Chair. I've just informed the Company Secretary of my appointment as a director for a company called SK Growth Limited, which is my consultancy business.
Thank you. Amin, any other changes to the declarations of interest? If not, brilliant. We will move on to the minutes of the Board of Directors meeting held on the 4th of March, which have been circulated. Are there any comments or corrections? Sarah?
Thank you. So it's not a correction, but I just wanted to raise it as a matter arising because it didn't get picked up as an action, and we just probably need to agree whether it is an action or not. But I asked whether we could be assured about the safety of patients who are in the very large cohort of patients who are past their indicative review date. I know previously we had a piece of work to provide assurance on the safety of patients on our very long waiting list as it was then. And just mindful that somebody may have an appointment that gets cancelled and pushed back and pushed back and pushed back, whether we see any impact on that patient potentially coming back into hospital for a non-elective, an urgent referral. And I know that the acting COO had undertaken to take that away and discuss with divisions. So I'm not asking for an update today because she's no longer in post, but if that's something we don't lose, that would be very helpful.
Smashing. Noted.
Thank you.
Any other comments or corrections to the minutes? If not, are we all happy to approve the minutes? Excellent. The action sheet and matters arising has been circulated. There's only one on there about the Provider Assurance Committee, which is in hand, that we are still seeking clarification on that. So we will swiftly move on to item 4 on the agenda, which is the Board of Directors Patient Experience Report. Lynn, do you want to introduce the item?
Thank you very much, Chair. This is a brilliant story. It's Abigail's story, and I'd like to welcome Heather, Abigail's mum, today. Thank you very much for coming to tell us the story. And Karen Perkins, who is our principal clinical scientist, and they're going to share a story about touch activated phlebotomy, which many of you will have seen on social media. So, and also Annette, thank you for supporting.
Thanks for inviting us. It's a great opportunity to meet you all. So Heather's here, but we've actually made a lot of video, which I think you've probably all seen by now. It seems to be everywhere, which is fantastic. I did a little search just before I came. So on this was picked up by NHS England on their Facebook page. There's 9.6 thousand reactions. And Ingrid very kindly and her team have pulled some data from that to see what the common themes are, what kind of reactions they are. They're all positive. The only negative reactions out of that nearly 10,000 reactions are ones saying, why do we not have this? How can I get this? This is difficult for me or my loved one. So that's wonderful. We've had 2,500 comments and over 2,000 shares on that post now. And those shares have gone to national bodies, international bodies. So we are literally viral on this now. So I'm not going to say any more. This is a 5-minute video that you've all seen, but you're going to see it again because it's wonderful. And I'd just like to acknowledge Janine Bevington from Gorgeous Media, who helped us with this. And she's done quite a bit of work with the Trust with video stuff and before, but she never gets credit for all of these things. And she is absolutely wonderful to work with. So please keep working with her. I'm going to hit play. So that's it. That's what we've done, hasn't it? And Heather's written that poem that she was reciting there, I think to help you cope with some of the difficulties that have been part of Abby's story, and it's not atypical in this patient population as well. We have so many parents and carers who have been very positive about what we've been trying to achieve. To date, we've accessed just over 80 patients across Morecambe Bay. We've rolled it out across the whole bay now in a phased process. So we've reached 80 patients who have really struggled to give blood samples before, never been able to give a blood sample before, and now they're coming back multiple times, such as Abby is. So it's really been a huge success. We've gained ICB-wide funding now to roll it out across the ICB, which is a massive achievement, but we struggle with staff and the usual complexities alongside that, and I'm happy to talk about that later. We've got contacts now with NHS Digital, NHS Pathology, Pathology Transformation and Diagnostics, who will want to support us build infrastructure to make this a more easy access route for blood testing for lots of different patient populations, not just this one. So it's definitely got a national platform now, which is fantastic. And you all know we've just been awarded the NHS Excellence Regional Award, which is another win-win for us. There's just one more thing. So yeah, it's about hospitals to community. We're very much fulfilling that role. It's about using a lot less blood than we usually do. So all our kit in the laboratories is designed to deal with adults, the big blood tubes that you would normally have with a venipuncture, but these are tiny, tiny tubes, tiny, tiny samples. So it's a step change in the way we deliver blood sciences now. There's technology changes coming through, and I'm very excited to be part of leading that change across the country and internationally now as well with the International Federation for Clinical Chemistry. And we have work groups specifically on total automation for capillary sampling now, which I'm very much involved with, and co-chairing a national group on that. So this is new, this is exciting, and Morecambe Bay is it. We are the only people in the country doing this right now, if not the world at the moment, for this patient population. So it's exciting beyond belief, but also very scary, and I still have a day job to do. So can you click to the next slide, please? So I like to be a bit of a disruptor in things and cause a bit of trouble wherever I go, as people know. So this slide is my trouble slide. So we've all 2P'd across the Lancashire teaching hospitals as pathology now, and Morecambe Bay's like, they've gone, that's it, it's not our problem. But we still serve our patients here. We are still located on site at all the hospital sites. The blue boxes are what's in scope for the pathology network, and that's going great. It's doing what it does. We'll get there eventually, and we'll tidy things up as we go. But what's not in scope is the red box. And this is the really important thing. This is the front end of our supply chain in the lab. If we've got rubbish products going in, we're going to have rubbish products going out. Our phlebotomists, we want to link with them so much more. We want to integrate with them. They would need to be part of our team. They need to be the people who are out there with the patient, building that bridge between the patient and the laboratory. We want to look at neighbourhood access, all the neighbourhood projects that are going on. How can we in pathology link with that? And I'm not just talking blood sciences, there's microbiology and maybe not so much histopathology, but the other disciplines as well need to come along with this journey as well. So that's what I'm putting to you all today, to have eyes on this and how better can we link that together and make it work really efficiently. We're leading the way at Morecambe Bay now, so let's take it and run with it. I'm going to leave it there unless you want to add anything else.
Okay, no one, just open to questions.
Well,
Thanks.
thank you for coming along and fascinating. And yes, we've all been sharing on social media, and you know, well done. I mean, it's incredible work. I'm open to questions now. Anybody want to kick us off? Perhaps if we take the slide down as well, we're getting conscious there's a few board members who are online, and it'll make it just for them to catch my eye. Susie, lead.
Comment rather than a question. I happened to have blood tests taken this morning by my GP at Captain French, and made a big deal of asking me, am I all right with needles, blah, blah, blah. And I said, absolutely fine, no problem at all. And I said, oh, and by the way, and then I told her about, she said, oh, yes, I know, we've got them.
Yeah.
Yeah, she was so proud of it. And she says it's been so effective.
Yeah, thank you.
I can't see any other hands. I'm going to use my chair's discretion. Oh, sorry, Sarah.
Sorry, Andrew, I was a bit slow to the party. Thank you for sharing it, and thank you to you and Abigail for creating that story as well. That was brilliant, and brilliant to see, so thank you. And my question is actually more for you as well. Just in terms of that call for how can phlebotomists work and how can pathologists work with the other teams and think about neighbourhood and communities. What are we doing about that? What is the opportunity for us to sort of take up that, ask really? I don't know. Sort of partly looking to our.
Yeah, I'm more than happy to have a conversation outside of here about how we can support that. Yeah, because I hadn't realised that phlebotomy wasn't part of the,
Or transport.
but I'll catch up with you.
Brilliant, thank you. And thank you for being such a passionate advocate for it as well and for leading the way on it. It's brilliant.
Thank you on behalf of parents from disability groups, because this has gone round disability forums online as well, with lots of people then saying, my child haven't been able to have bloods for 2 years, or the last time they had to have a general anaesthetic to have bloods. How can we, and Karen and liaising with people involved with this have been able to facilitate that.
Yeah, there's a lot of energy in those Facebook reactions to help drive this forward now. And hopefully the webinar question and answer session we're organising will help us build how do we then approach, well, we've already approached NHS England with it, and they're open and receptive to it. I think the power of the patient voice is far bigger than a spotty nerdy scientist in a lab coat, isn't it? Yeah.
Steve.
Karen, what an inspirational presentation and experience to hear. So I wanted to acknowledge that and say thank you. And if there's anything I can do to support the engagement with the services that Lynn's already offered, I'm very happy to do that. I assume we've already kind of showcased this everywhere, but if there's anything we could do in the Northwest region to help bring this to the kind of focus of other chief executives, I'd love to support you.
That would be really great, actually, because while it's all very much out there, locally, there's not that much drive and support for it, to be honest, yet.
Well, perhaps if you're not
so that would be
brief conversation, we'll see what we can do to
that would
that.
be wonderful, yes.
But I also want to say thank you to Heather. The bravery of sharing this story, that's incredible, and it's helped change us. So thank you for that. Are there any other areas that you saw that we should think about improving elsewhere? Are there any other aspects or learnings that you have experienced on that journey with Abigail?
Pediatrics. Yeah, pediatrics. So one of the problems I found with this is it went out and it says UHMB are doing this, but parents were commenting back, my child goes to UHMB. It's torture, it's terrible, it's absolutely dreadful. They can't have bloods taken there, they're having to be sedated. With anaesthetists there, they're having to have GAs for blood tests. And we didn't have it done at UHMB on paediatrics because it wasn't being used there. We had it done at the GP surgery with people that the UHMB lab team had trained to do it. So I think having this available and accessible on paediatrics would be great. Because for Abby's desensitisation work, we were going once a month for at least an hour to paediatrics with 3 members of paediatrics staff there to do desensitisation, and we weren't getting a blood test. We got 1 blood test after 6 months. So that's 18 hours of staff time, 1 blood test against something that takes 10 minutes and she's happy. So that was just
That's really helpful. Thank you so much.
Peds at the end.
So if I could ask through my executive colleagues, Lynn, if we could look at the options and the steps.
Yeah. I would like to acknowledge the fantastic work, especially of a lady called Kerry Heaton, who's the specialist nurse who does all the desensitisation work with children. Just because she's been brilliant.
She's like the world's best paediatric nurse. She is totally, she's amazing.
Can we say thank you to Abigail as well?
I'll thank her when I get home. She'll be pleased to know she was discussed. She does think she's a film star now.
I'm going to go to Scott next.
I just wondered maybe Heather, obviously I presume Abby at some stage has been engaged with Lancashire South Cumbria Foundation Trust, where a lot of our young people with learning disabilities are plugged in. So they've obviously they'll have children and young people and adults across the whole of Lancashire South Cumbria. And I know they collaborate really tightly with the learning disability providers in Cheshire and Mersey and Greater Manchester for the North West. So has there been any active conversation in the broader learning disabilities providers around this?
I don't know because I'm not directly linked in with them.
Yeah.
We did have a learning disability nurse come and visit us at one point, but it was just for an assessment and I think there was no input deemed needed.
We have run this project very tightly with the learning disability team at Lancashire South Cumbria. So Jenny Pratt and it was Sarah Duffin before Jenny. Sarah's now up at University of Cumbria, but she's still part of the team, so we still loop her in and use her brain. But they're a very small, very limited, very thinly spread team. We couldn't have rolled this out across the bay without them. They know who the patients are, they know where they are, and they know how to get to them as well.
So it's Jenny Pratt's when I've had parents contacting me saying, help, we need help. It's her that's sorted it out.
Thank you.
Thanks. Lou?
It was just really back up in terms of, I'm the Director of Comms and Engagement, so Ingrid's in my team. So in terms of the sharing, it is probably one of the most, if not the most popular posts that we've shared, you know, in terms of not just on our social media, but the media coverage and everything that we've had. And I know, because I also look after the charity, and I know that they're getting inundated with parents across the country saying how do we access this, how can we even telling stories of children that they still don't have a diagnosis because they need to have these tests done and the children just can't do it. So the impact it's having nationwide is unbelievable, so thank you.
There is a slight sting in the tail with this though, and that's that the TAP device is no longer available in the UK as of the 1st of April. But the company, they funded the video for us. They love the project that we've done so much that they've sent me 8 boxes for free, which is about 8 to 10 months worth of TAP devices, so we can transition. I'm just waiting for a couple of devices to get the regulatory approval in this country, and hopefully they'll be on the market in the next few months. So we'll be transitioning to a slightly different device. So it won't be TAP because that's a trademarked name, but it will be an upper arm transdermal capillary sampling device, which is not as snappy, but
Need to find another clever name.
Abby will always
it will always be
It'll always
TAP.
be
I think
TAP.
this population will always be TAP, but so be it.
Karen?
Oh, thank you. Thank you. Honestly, I'm just completely inspired by this story and the work you've done. Absolutely brilliant. I'm thinking 2 things that we could learn from you even more. One question for Heather and one for Karen. So to Heather, it's are there other experiences and services that you and Abigail have engaged with where you think actually we could do an awful lot better? So this is absolutely brilliant for blood tests, but actually what are the other things that haven't gone so well that we could learn even more about and make more experiences for yourself and Abby and other families much better? So that's the first question. And the second in for Karen is, Karen, it's a bit of how do we bottle your magic? So so you have clearly got a particular leadership style that is nothing to do with being a spotty, nerdy scientist, or maybe it is. But actually, what are the things that you've done, that you've achieved, the buttons that you've pressed, the doors that you've nudged open? I think if we can really understand some of the root cause of your success with this, we could really work to make it happen more often in other places with other services. So question for each of you really, and maybe we need to continue the conversation after today to really get to grips with that properly.
Thank you, Karen. I'll hand that to Heather first of all.
Yes, from me, there are as a parent of a child with additional needs, there are so many things that are a battle and so many things that are difficult and don't go as well as they could. Just reflecting since you asked that question, actually, the health side of things has been pretty good. So bloods have been a major thing, but apart from that, health-wise, I think the Trust has done pretty amazingly. We have regular checkups with our paediatric consultant. We have Abby accesses ophthalmology, orthoptics, audiology, orthotics, and I have to say that all of those services act really well. They interact very well with Abigail. Their regular appointments, and if we need somebody before the time that the appointment's due, we can contact them via email and they'll get back to us. So as a general thing, health is good. I think many more of the stresses come from education and social care. So yeah, but no, thank you.
Thank you.
I'm not quite sure how to answer the other part, Karen. It's taken a lot of whiskey, I'll be honest. There's a lot I'd like to say that shouldn't be minuted, so maybe we should hook up later. But
Yeah, really, seriously, Karen, really happy to do that. So we can we can actually really understand some of the practical actions and practical steps that you've taken that really kind of underpin the success of this, so that we can try to apply them elsewhere too. But really happy to have a conversation following on from today, if that would work for you too.
I think most of it, well, it came out because both Andrew Brown, who's our consultant clinical scientist, and myself, we share an office, and we both had phone calls within a week asking similar questions. I have a patient who's has learning disabilities, desperately needle phobic, and they desperately need a TSH doing. What can I do? So yeah, we just kind of looked around, and I got stuck in a rabbit hole on the internet and found these. So yeah, it was quite simple really. But the journey after that has been, yeah, born of frustration and determination, and everyone cheering me on, I think. So,
Okay, thank you, and we'll connect afterwards, because I think there's lots to understand about what you've done. That's just phenomenal, and sometimes when you're in the thick of it, you don't always credit yourself with all the things you're doing. So yeah, let's have that chat. I'd really welcome that.
And the uniqueness of this project has been a huge collaboration between primary care, mental health, learning disability services, and blood sciences,
Yeah.
and the patients and the carers. So it's been everybody involved, not just us.
Okay, thank you. Sounds like a brilliant case study to me.
Great. As I can't see any other hands, I'm going to, and we've got time, I'm going to use my chair's, yeah, I'm going to use my chair's discretion to bring in Sean, one of our governors who's observing the meeting. Sean.
Thank you. I presume these are single-use devices and have a cost. And I know that the time saving will probably offset that in children and special needs.
Yes.
But if you start moving it out to needle phobic patients, you'll be surprised how many patients then find out, oh, I'm needle phobic as well, I'd like it. So is there some cost implication of it is to move out to needle phobic?
Not at this stage for general needle phobics. There's a lot of case studies, mostly in North America and some across Europe, looking at how to keep people engaged in healthcare. So there's a big statistic in the States. I think 60% of patients avoid a healthcare appointment because of their fear of needles, which I don't know if that's because they're American or what, I don't know. It's these, you know, those facts are out there, and it's surprising how many people you speak to think, oh, I hate having my blood test done. I really struggle with it. I get so anxious, and it shouldn't be that way when we've got another way of doing it. It's a very early stage in this technology, so there are a lot of changes coming through. It's not a perfect science. We can't do a full blood count on them yet, so it's not suitable for everybody. Things like a potassium we struggle with, which you would need for a renal patient. So yeah, it's horses for courses. It's not for everybody just yet. And yes, there is a cost to it, but if you keep the patient group very focused that you're applying it to, then there are serious benefits for it.
Right. Jalabani.
First of all, thank you very much for your perseverance into making this happen. Really appreciate Abby, our hero, for actually agreeing to be filmed and for also giving the feedback. My question, so there's a suggestion, maybe not for you per se, but in terms of the experience of other patients and staff, how they're finding that useful, because we would need, I think it would be good to utilize that evidence to make sure that we cascade that widely. My only concern is the device.
Can everyone online, please? Sorry, Brian, can you just mute? You will mute you. Continue, John.
Yeah, in terms of the device being approved or identifying an alternative, you mentioned that you've got 8 months. Now, this is amazing. I'm worried that we might find ourselves without an alternative.
I'm determined that's not going to happen. So since the video came out and since Your Bio Health, the company that make the device, supported us to make the video and announced that they can't supply it in the UK anymore for contractual reasons, they've been taken over by a big American diagnostics company, and they now are the sole suppliers for that company. But since that's happened, before that happened, I was exploring what else is out there, what else can we use? You know, you should never put all your eggs in one basket, right? So I've built some really good working relationships with people from other companies that make these devices. There is one on the market, the Tasso device, which is used commercially very widely across the UK at the moment with Randox Health, a company called Thriver. They're very much in this workspace at the moment. So there is an option out there already that we could use. Heather's had a play with a couple of them. So she's my biggest critic. So what would be acceptable and what wouldn't be. And I've got now a selection box of devices. So the companies are falling over themselves to come because they've heard how wonderful this is. And it's got such international attention now that they want to be part of it. And now NHS England have got into it. I'm hoping that will help lever some motivation towards providing whatever the next device is. Yeah, it'll happen. But yeah, it's scary, but it'll happen.
Well done, Karen, Heather. Thank you so much for coming along today. Thank you for sharing Abigail's story.
Thanks for your time.
You're welcome. Thank you. Thank you, Ellen.
Thank you. So swiftly moving on, we will go to the chair's report. I will take it as read. Again, obviously welcoming Steve, our new CEO, to his first board meeting. Can I reiterate what I said at the start of my report, put on record my thanks to Scott McLean for everything he did over 6 months as our interim CEO. And I was particularly proud in Scott's final week. He got to give a presentation to the North West System Leaders meeting, which included Sir Jim Mackey and Penny Dash, about the integrated wellness service and the transformational benefit that's delivering for living in the parts of the trust where that service is already operational, and obviously patients in other parts of the trust are eager for the expansion, which will happen shortly, I am sure. So with that, I don't wish to verbalise any other part of my report. Happy to take any questions that there are on my report, and I'm hoping there are none, because that allows me to move on to the far more interesting report. I will hand over to Steve for the Chief Executive's report.
Great, thank you, Andrew. I'll take the report as read, but there are 4 or 5 areas I want to say a little bit more about, so I'll cover those. But firstly, just recognising this is my first public board, to say I'm delighted to have been appointed. I'm privileged to have the role and very grateful for the support of board colleagues. I think colleagues are aware that for the last 10 years, my experience as Chief Executive has been in leading rural, regional, coastal, peninsular and geographically isolated health services. I've loved that challenge, and I've seen through those previous roles the importance that local communities rightly place on their health services. So I hope that experience complements the experience in this board and in this organisation, and I'm certainly looking forward to helping colleagues across Morecambe Bay on our journey to create a great place to be cared for and a great place to work. This is, I think, day 8, as you mentioned. So there's lots of our organisation I've not yet had the opportunity to spend time in, but I have spent time at Furness General Hospital, at Royal Lancaster Infirmary, at Westmoreland General Hospital, and with a number of our community teams. So apologies to those services I've not been to yet and colleagues I've not met, but it's been really helpful to spend time with our intensive care units, our emergency departments, our acute medical units, our same-day emergency care services, some of our wards, district nurses, integrated stroke teams, operating theatres, and I also spent an evening in shadowing some of our ED colleagues at Furness General Hospital on Friday last week, and I'll be doing the same on Friday this week at RLI. And I will be looking for every opportunity to spend time alongside our staff in our services and alongside our patients and with our community partners across the wider health and care system. Thank you to everybody I've met so far, Andrew. People have been incredibly welcoming, very, very friendly, and very open about the things that we do really well and the things that we need to improve. And that also goes for our patients. I've talked to as many patients as I was able to over the course of the last week or so. To any of our staff, colleagues who might be watching this meeting, if there's an area I've not been to yet, if you haven't seen me, please reach out and I'll do my very best to visit those services I'm not been to. I'm certainly looking forward to going to Mullum, to Ulverston and Queen Victoria over the coming weeks, as well as visiting some of our partner organisations. The bits of the report I wanted to particularly draw to board's attention are first the staff survey. I do mention that in the report, and clearly we do have a substantive agenda item, agenda item 10, where Rebecca will take us through the details. But to recognise that in my first Chief Executive report, the staff survey, the Workforce Race Equality Standard results and the Workforce Disability Equality Standard results are all really important to us as a board and to our organisation. And we'll see we do face a number of challenges in those areas. So I don't want to preempt that discussion, but to recognise that in some areas we have seen improvement in the Workforce Race Equality Standard, as board members will have seen. There is a reduction and improvement in the proportion and number of colleagues from different ethnic minorities who report that they're subject to discrimination from other members of our organisations. That's a really important positive step forward, and that's an area I know that all board members want to see improve going forward. We've also, as you'll have seen an improvement in staff feeling safe to speak up about clinical concerns. That's really important, and as Chief Executive, that's something I seek to always personally champion. I'd want everybody across our organisation to feel it is always safe to speak up with a clinical concern. What I would like us to arrive at is colleagues feel safe to speak up openly in every instance, with that safeguard where, for whatever reason, if colleagues don't feel safe to speak up openly, they can speak up confidentially through the freedom to speak up mechanism. So it's welcome to see that improvement. But I think overall what we see is significant deterioration in staff experience across the organisation. And that will absolutely be a priority for me to work with executive colleagues and colleagues across the organisation to see improvements there. The next thing I was going to update on was the actions that the Trust has taken to ensure the safety of patients in intensive care for those patients in Barrow and Furness at Furness General Hospital. So Section 40 of the report sets out a summary of the actions that the organisation has taken to ensure the safe care of ICU patients at Furness General Hospital. You'll see the report sets out 3 particular areas of focus. Firstly, the ongoing process around the future of level 3 intensive care, inpatient care at Furness General Hospital. Secondly, the work that the Trust is progressing needs to continue to improve the care of deteriorating patients in Furness General Hospital. And then finally, the emerging fragility that we've seen in some parts of the clinical workforce at Furness General Hospital. So those 3 things particularly form part of the core work of the executive team in this board to continue to ensure local access where that's safe and to take action where action needs to be taken to improve the safety of patients. You'll see in the report that we set out in some detail the work we're doing with the Critical Care Network, with our Lancashire and South Cumbria Integrated Care Board, and then the work we are subsequently progressing to undertake a second independent review with the North Eastern Yorkshire Clinical Senate. As board members are aware, around 80 patients a year, just over 1 patient a week, would currently be impacted by the need to stabilise and then transfer patients for level 3 care to the Royal Lancaster Infirmary. In my first week, I did spend some time at Furness General Hospital Intensive Care Unit and Royal Lancaster Infirmary Intensive Care Unit staff were very open. I'm very grateful for the time that staff in the intensive care units gave me to explain the processes, the actions, and the mechanisms that are in place. The other two items I was going to update on briefly were the report sets out the financial results, which of course are subject to normal audit processes for 2025-26. And that highlights the significant progress the Trust was able to make in the last quarter of the operational year to significantly improve the forecast and actual financial deficit. So the position subject to audit as set out in the report is a deficit of 6.1 million. That is a significant improvement on the forecast really only a couple of months ago, but does highlight the level of financial pressure that we continue to operate in this organisation. And I know that's the case across many other parts of the NHS. So it will continue clearly to be an area of priority for the Trust to continue to operate safely within the resources that are allocated to it. And then the final thing I wanted just to draw Board's attention to, although it's in the report in section 61, is the summary that we provide for the investments in Royal Lancaster Infirmary's maternity triage units and the Willow Bereavement Suite. I wanted to mention that because I had the opportunity last week to go and see both of those services. They're fantastic facilities and amazing staff. So it was a pleasure as a new chief executive to see the quality of the physical environment and the great services staff that we have. We're rightly proud of the care that they provide in both the maternity triage unit, providing 24/7 service to mums right across the Bay, and also to see the environment that we provide in this most difficult, tragic and traumatic of circumstances in the Willow Bereavement Suite. So thank you to everybody giving me their time when I spent time at Royal Lancaster Infirmary. I'm happy to take any questions on any of those or anything else that's in the report.
Thank you, Steve. Open it up for questions. Any questions from anyone? Sarah?
Thank you. Probably less questions, but partly question, partly to follow up. So I think first of all, I want to say I really welcome the focus in your report on workforce experience and also patient experience in terms of ethnicity and disability. I think it was really good to see that included in such an open way, along with the sort of that we're taking, particularly in the first instance, to improve the ethnicity data collection. A bit of an offer from Quality Assurance Committee perspective, because I noted that the Health Equity Committee will be will hold that. So that committee reports to Quality Assurance Committee. So I think if that could be picked up as part of the 3A's reporting from Health Equity Committee, so that we can keep some assurance around the progress of that would be really helpful.
That's right.
Yeah, so because obviously it's patient experience, I think it's really important it comes there. So I would just want to follow up really by keeping it in our side. Again, really welcome the way you're talking about that focus on enabling staff to feel able to speak up. It's something, obviously, it's a culture that we all want to have. So it's really great to see that coming out as one of your first things in the report. Really welcome that. And then the other thing I did just want to mention in terms of the update on Furness General Hospital. So that's something the Quality Assurance Committee has been receiving updates on. We received a paper on that at the last meeting of the committee. So Helen obviously was leading that with surgery and families. And we've requested an update for the next committee meeting, and we also just did agree, because we know it's an area that's quite fast moving, and the moving from it being about intensive care to deteriorating patient is a good step. So we're also sort of mindful that if in the meantime we need to sort of convene Quality Assurance Committee or look at any potential patient quality and safety issues, that's something that the committee's open to doing as well, so that we can support as well in terms of looking for that assurance on the ongoing safety.
That's very helpful, thank you. And just to add from a staff experience perspective, I'll shortly be meeting our staff side chair and secretary, and I'm looking forward to working with our union colleagues, including through the joint negotiating and consultative committee, to find ways where we can align on jointly working together to create the kind of environment you described and the opportunities that can enable from the patient experience as well. Thanks.
Karen.
Oh, thank you. Thank you, Steve. And very much echoing Sarah's point about really welcome your focus on people, and that really reflects a really strongly refreshed focus on people since about February of this year. And what I would really welcome, and People Committee would really welcome, is your fresh eyes and perspectives on the plans that we'll see Rebecca reporting for us later today. So following a recent board workshop and then conversation at executive directors and trust management group, we've got some really clear actions resulting in some really firm grip, and then that echoed through our divisions. But it would be really helpful to triangulate all of that with your insights and reflections as you're meeting staff and connecting with those staff. So your fresh eyes on that will be very welcome, particularly in making the assurance that we bring through People Committee as strong as it can be. So really look forward to hearing more about that as you meet more and more of our workforce colleagues. Thank you.
Thank you, Karen.
Great. If there are no further comments or questions, sorry, Susie, apologies.
I'm going to say reluctant, but I'm going to have to say it. Is VCR on the ethnicity data recording when you said it's not complete because people don't necessarily give it. There's one section which isn't complete because you don't even ask it, which is we have in the staff survey, tiny number of people who are marked as Jewish. That marks the people who say they follow Judaism in the religion question. I'm an atheist, but I'm Jewish. But I have no way of recording that. I can put white other, but that doesn't actually say. And for the last couple of months, this has actually become quite acutely important.
Yes.
For us to know how many of, we're a medical establishment, for God's sakes, we're going to have more than the number that is recorded. And I don't know if this is national data, so I don't know how we can work around it. But I just want to say that there is actually a big issue there, which has become, to my view at the moment, pretty acute. And who knows? Absolutely.
Thank you, Susie. And that is, I think, really important, setting out a very clear challenge for us. And some of that would be national. So I take guidance from Rebecca, but I think there are a couple of aspects. One is the ability for staff to record that on the staff survey, but there's also then a separate but important question about the ability of staff to record that on our own internal information and staff record systems, and ideally we'd achieve both of those aspects. But even if we're not able to change the national recording, I would want us to look at the current arrangements for recording of information. And I think I'd say to staff that the more insight we have across our organisation, the better that helps us to address hatred, discrimination, and inequity for staff across our organisation. That's the only reason we ask for that information, to help us to inform what actions we can take to support colleagues. So perhaps it's something, Rebecca, we could consider and then report back to board in the future as to what additional reporting mechanisms are possible, if that's okay, Susie.
Thanks. There are no further comments or questions. We will move on to item 7, which is the lead governance report. Susie, over to you.
Right, take it as read. But hang on, let me get my own report up. 2 things to note. Firstly, welcome, Steve, and we'll be seeing you properly at our own Council of Governors next week. The other thing to just point out, to highlight, is that the 10-year plan is now, NHS England have now sort of pointed out that it actually is going to involve eradicating the Council of Governors. And we have been discussing this, we've had an opportunity to discuss this. We are hopefully going to discuss it more fully at the Council of Governors. And I think we're bringing it to the meeting, which is the COG and the CEO, well, and the board. Because it is quite a far-reaching and interesting development. you know, what's going to replace it, and you know, what do we do? I know that having talked to other league governors, they are not as welcome, shall we say, their trust as ours always has been, and therefore I think we can perhaps bring something out of this which is going to be helpful to the trust. Other governors, perhaps other councils, are not having the same experience. That's the only thing I'd like to highlight. Take it the rest as read. Anybody asking questions, very welcome.
Okay, thank you, Susie. Any questions for Susie on her report? No. Great. We will move on to item 8 then, maternity update report. Lynn.
Thank you, Chair. So I'll hand over to Susan Foyle, Director of Midwifery, to present this report, please.
Hello, can I just check you can hear me?
Yes, we can.
Thank you. Okay, take the paper as read. Just in terms of strategy, we've now completed phase 2 of the cultural improvement plan, and we've embarked on phase 3, which is inclusive of the neonatal nursing and midwifery leadership programme. First 2 cohorts are now completed and evaluated, and that evaluation is excellent, actually. So we're just doing cohorts 3 and 4 now. And we've also started a piece of work with our OD team to strengthen the obstetrics and gynecology teams across the Bay, much in the same way as we've done midwifery, just to get us all on that trajectory. So that's been really helpful. Our risks are stable at the moment. We've got no extreme risk, and all risks have action plans updated and to move towards risk that is within the organisational tolerance. I do have a little bit of news around the MIS Year 7. It's not in the report. It came after we'd done the report, but we've been notified that we've now been marked as fully compliant with Safety Action 1. If you remember, there was a little bit of a query because we'd missed reporting one of the stillbirths to Embrace, and we had a mitigation around that. We also stepped up and developed a different system. We noticed that we got a single point of failure when somebody was absent from the workforce. So we've now had a notification that we've been marked as fully compliant, and therefore we will receive the full rebate as per last year. So that's a bit of good news for us. In terms of MIS Year 8, that has just been launched this last week. There are some changes to the reporting to board, and we presented those to QAC last time, and those changes and the reviewed schedule has been accepted by QAC. I think I'll stop there. The only other thing that came out of QAC is just for the fill rates, for the staffing fill rates, we've been asked to RAG rate them, which we're going to do. But also we just need to be mindful that when fill rates are lower, sometimes we make a decision on filling depending on the occupancy of the unit. So if, for instance, the special care baby unit at Furness has only got 1 baby, we don't fill to full capacity because there's only 1 baby to look after. So we take into account when we're doing the fill rates, we take into account the occupancy and demand in the unit, and that is, good financial governance as well. I'll stop there and see if there's any questions.
Thank you, Sue. Open it to questions or comments. I'm not seeing any hands. So thank you, Sue, for joining us. Thank you, Lynn. Thank you for that report.
Sorry, Chair. Keith has got his hand up. I'm not sure you can see it. Keith's online.
Thank you. That's very helpful. So, Keith.
Yeah, thank you, Sue. It was only just to say very well done for the team for the CQC rating for the maternity unit. I think that's an excellent achievement. And I didn't think it was fair to let that one pass without passing comment. So well done, Sue.
Thank you. Thanks very much.
Thanks for flagging that, Keith. If there are no further comments, are we happy to receive and approve the report for assurance purposes? Yes. Good. Thank you, Sue, for joining us. We will now move.
Okay, thank you. Bye.
Thanks. We'll now move on to item 9, the integrated performance dashboard and report for month 11.
Thank you, Andrew. So, as board members are very used to, this presents the integrated performance report. For any colleagues that might be watching the board, if this is the first time you've joined us, you'll see in the report, the first part of the report, the first 2 pages provide a summary of some of the key areas of risk or compliance or issue, and then a detailed report sets out all performance areas. So I'm going to ask my executive colleagues in a moment to take us through a summary of quality and safety, then people, then finance, then operational delivery. If I could just draw board members' attention to a couple of those areas. So I know this will be no surprise, but our urgent and emergency care performance continues to be a significant challenge, and 12-hour performance in the emergency department and ambulance handover performance continue to be a long way short of the experience that we would want for our patients. I've seen that firsthand in the time that I've spent in this organisation. I particularly saw that when I was in Furness General Hospital Emergency Department on Friday evening last week and saw the volume of patients waiting in the waiting room and heard directly from patients of their experience being cared for and waiting in a corridor in that example on that evening due to the pressures that we face. And I know we know this, but those urgent and emergency care indicators are not just performance indicators, they're quality and safety measures and their patient experience measures as well. Also mindful of the mixed sex accommodation breaches and the experience that has for individual patients and for their families from a privacy, a dignity and an experience perspective. And also mindful of the appraisal compliance performance, and that is an important part of how we work with and support our colleagues across the organisation. So I'm sure colleagues will touch on those. But if I could go firstly from a quality and safety perspective to Helen and Lynn for any matters that you want to highlight to the board.
I'll start and then I'll hand over to Helen. So our patient safety incidents per 1,000 days have shown 4 consecutive months below the mean. That could indicate sort of that people aren't reporting. So we are sort of maintaining a focus on the importance of completing patient safety incidents. Alongside of that, we have a decrease in incidents reporting moderate above harm. From a PSERF perspective, no never events in February 26. We've had 1 staff reporting incident meeting national priority, which is death considered likely. PSI has been commissioned, so patient safety incident review has been commissioned for that. We do still have a problem with the backlog of patient safety incidents being completed. We do have all the staff, the patient safety, the PSI investigators, we have them all in post now, but there's a training issue, so we're continuing to use bank. We are starting to see those, the longest backlogs come through the learning response group now, so that's an improvement. We are just reviewing the local priorities for the patient safety incident framework. We have a long list of 15, and that's gone out to consultation for people to decide what would be the 5 local priorities for this year. I don't have, the only thing I want to say about falls is we've had 0 moderate harms from falls in surgery and families for over a year, which is really good, and 0 moderate harms for the first time in month. And I know it's only 1 month, but I think it's worth noting that. Pressure ulcers, no category 4 pressure ulcers for about 2 years. Infection prevention, some improvements there. Year-to-date improvement on Clostridium difficile infections, gram-negative bloodstream infections, showing a year-to-date improvement. We do have an issue with methicillin sensitive infections, and we're looking at blood culture contamination, because we feel it's contamination rather than infection, and no MRSA cases since February 25. We have an issue with complaints right up to the 6-month mark. We have an ambition to, which is probably not ambitious enough, to get below 5 months, but we are struggling for those complaints between 5 and 6 months. I've authorised extra bank support with current resources to put in additional support, and identified some additional whole-time equivalent spare that can move over into patient relations, which will hopefully, in the short term and the medium term, improve that position. I think the only other thing just to note is family and friends tests. We moved this year into an in-house solution to delivering the family and friends test. Previously, we were paying an external company an extortionate amount of money. So using our own BI teams, we now have an in-house solution, and you can see month on month those FFT responses are improving the numbers, but also the percentages are sort of about where they were last time. I think there's an opportunity across the system to look at doing a similar thing. And then you've already mentioned mixed sex accommodation. We do have an opportunity at Furness General to do something different with the patients, given the footprint that they've got. All of the MSA breaches, apart from 2, they're always in ICU, never outside ICU. The only other place we have breaches in medicine in the stroke assessment area, and that's usually overnight because of pressures on site, and that'll go through the site managers, but it is something we keep our focus on, but it's quite an intractable problem. The other thing of note, alongside mixed sex breaches at Furness General, is last year they had 78 patients discharged from the ICU home, which just gives you the scale of the problem of patient movement at times at Furness General. And I'll hand over to Helen.
Thank you. So first of all, just to cover the VTE or venous thromboembolism assessment. So that's, as we've talked about before, is looking at the risk of getting a hospital-acquired thromboembolism, so deep vein thrombosis or pulmonary embolus. We should be hitting 95%, so it's not where we want it to be, but there has been sustained improvement. And you can see there for March, we hit 82.8% of patients being assessed. There's a breakdown there by division, and it's one of the areas that we concentrate on in our monthly performance meetings, as well as weekly discussions with our divisional chief medical officers. There's a lot of improvement work that's happened. There's more that's ongoing. I've literally just approved a cohort risk assessment that we've done, which has been looking at our risk for cohorts of patients, in this case, looking at patients in our cardiac unit, non-inpatient, and looking at whether we're able to look at risk across a cohort of patients, which we were in terms of being able to mitigate any risk. So we've pulled together a standard operating procedure that will mean that any cohorts that become excluded effectively, or that we risk assess together, will be looked at by myself using the statistics to make sure that we're not missing any risk of harm. That will continue to improve our trajectory to head towards, obviously, the 95% we should be hitting. The second is just around mortality. We've talked before in terms of our summary hospital mortality indicator, or SHIMI, is not where we would want it to be, which is 100 or lower. As noted there, that's 138 with 9 red alerts. Those are detailed there. As part of how we mitigate for any concerns really around obviously our mortality, particularly with those 9 unearthing, our medical examiners are aware of that, and so they're able to particularly flag any structured judgment reviews that we're doing, mortality reviews that we'll be doing. The reason behind our worsening SHIMI is related to our coding delays, and this is to do with the number of expected deaths versus our observed deaths. And we can see from the graphs that with our coding delays that have occurred since January 2025, we've had ongoing issues in terms of our SHIMI. So we've not had any increase in our observed deaths. It's to do with the reduction in our expected deaths due to the coding delays.
Should we pause to take questions, Andrew, on quality and safety before we then move into people?
Yep, happy with that. Any questions for Lynn or Helen on what we've just heard? Sarah?
So I don't have questions as such because we have discussed all of that through Quality Assurance Committee, but there were a couple of points that I did want to draw out, partly related to your intro actually, Steve, as well. So very, very much cited on the mortality data and obviously very supportive of all efforts to improve the coding situation, both in terms of workforce and improving coding for the impacts on mortality data. In terms of the emergency department, I did just want to pick up that point you made actually, Steve, is that it's measured as a performance metric, but actually it impacts on people and patients and quality and safety. And so something that the committee actually received at the last meeting was a thematic review related to emergency medicine deaths that are taking place outside of clinical areas. We received an update on that from the nursing lead for MEX and including the action plan that had been put in place. So we were reassured that it wasn't caused by a spike in deaths per se, it was about where the deaths were taking place, and also that they weren't they weren't deemed avoidable, so it wasn't specific impact on them. But obviously not a good experience either for the patients or staff and colleagues and of course other people there as well. So we have asked for the action plan to come back to Quality Assurance Committee with clear accountabilities and timelines, because we didn't feel that was entirely clear in terms of the actions related to that being embedded. But the other key thing for me was just making sure that we triangulate between the quality and safety and what we're doing about corridor care as well, and how that interrelates with the transformation and improvement programme, which was something I flagged to Tony as chair of the TIB, so that we don't lose sight of that quality and safety impact. So I did just want to highlight that one. I just wanted to check if there's anything else related to this report. Obviously we talked about venous thromboembolism. We continue to have that focus on improving the trajectory for that. The other thing I did want to talk about was the complaints situation. So it is something that Quality Assurance Committee has been flagging, that there's a risk that we might breach the 6-month complaints in terms of closing complaints in 6 months. And I wanted to triangulate it actually with the coroner's report on the prevention of future deaths notice, which highlighted fragility in the clinical governance team over a period of time. And Lynn has just spoken to that, I think, a little bit in terms of making sure there's sufficient resource within patient relations to support both complaints and incident PFIs. And so that's something that Quality Committee is keeping a really strong focus on, and that when we look at workforce and management of vacancies, it's really important we don't lose sight of the impact that can happen through gaps in clinical governance, for example, impacting on our ability to maintain quality and safety and our sort of constitutional standards as well. So we're very supportive of the actions that are being taken in that space, whilst recognising that we're not supposed to we're not supposed to be involved in the finance side of things, but we recognise it's a balance, but it's really important we don't lose sight of that. Thank you.
Further questions or comments, Steve?
Well, I think that's a really helpful summary on all of those areas. I'd also recognise, from the perspective of the patient or one of their family members, if they're waiting even for 5 months for the outcome of a complaint, that's an extraordinary length of time, and the uncertainty, the worry, the additional trauma that can arise from that. So notwithstanding 5 months must be better than 6 months. Do we need some further work to set out what would be necessary to bring that down to 3 months or shorter, and whether there's an action to ask Lynn to either bring that existing work forward or develop what that set of actions would look like, and perhaps that would go to quality and safety. I do wonder as well, Andrew, on the coding aspects. Helen and I have had the opportunity to talk about some of the challenges around that, but just given the materiality of their impacts, whether that's an action that we need to frame from the board to perhaps to Helen and I about what would need to happen within the One LSA environment or within this organisation to be able to address that. And I was going to raise this when we come to operational aspects, but I know our executive directors group is receiving a UEC improvement plan at its next meeting next week. Just given the challenges that we have currently around those patients who experience corridor care and the experience of delays in the emergency department, whether we need to kind of formally recognise from the board that being a third action to be able to provide assurance via a number of committees potentially, but to come back to board with the actions and the steps necessary, or the assurance executive director colleagues have in being able to accelerate that improvement trajectory.
They all sound logical actions to me if everybody's in agreement. Yep. Good. Are there any further questions on this section of the IPR to Helen or Lynn? Questions or comments? Yep.
So if not, if we can then move on to the people domain and ask Rebecca to summarise that.
Yeah, thank you. So in terms of the looking after our people section, so we did end the year slightly over target in terms of absence, although we have seen a decline from a peak in November. So the people services team continue to do a couple of pieces of work around this. Bespoke training into divisions around absence management and support of managers, as well as continuing to deliver the people manager development programme, of which a day focuses around that topic particularly. We still get really good engagement with those sessions, so hopefully we see that absence continue to reduce. In terms of belonging in the NHS, I think the significant thing there was the launch of the clinical leadership programme. I don't know if Helen wants to come in there and add anything to that. So that's a 24-month programme for clinical leaders, and it was a really successful launch, wasn't it?
It was. It's really covering all aspects of clinical leads, and obviously when we're talking about clinical leads, we're talking about our medical leaders in departments, but also particularly focusing on how they can get involved in service improvement with their frontline teams as well as covering some really important things around people management, finance, quality and safety, the whole range, which I kicked off the first session, and we got some great feedback. So we're doing 4 full days each year for 2 years to upskill, and we'll be very much be led by our clinical leads about how they want to sort of have different topics and things like that moving forward as well.
Thank you. In terms of growing for the future, so on the vacancy position, all I would add to that is to say that the vacancy control panel process, which has been in existence for about 12 to 18 months now, I think has now been formalised into the trust governance structure. So that's a combination of divisional vacancy control and review, as well as corporate vacancy control and review. And on the final section, the core skills that are mentioned on there, we did pick those up in the performance reviews, so we will expect to see some improvement in those compliance rates next time around. Appraisal, if I can mention that, so again that is a regular feature in the performance review discussion, with each of the divisions having a plan in terms of reaching full compliance. A couple of things are happening in the appraisal space just to mention. So the people services team have developed some new tools to support managers with this, and we've talked previously in this forum around how do we measure the quality of appraisals. So we are developing with the BI team a couple of forms for TMS, so that'll be for appraisers and appraisees to complete and report back on the quality of that appraisal experience. So again, we'll look to how we build that, the monitoring of that into the existing governance framework and the reviews that we have. The toolkits focus on having enhanced one-to-ones, for want of a better description, and that fits with what we see in coming through the NHS England management and leadership competency framework. There's a real focus on that through that. And we are expecting a new national framework around appraisal, which again will focus on quality one-to-ones. So we're preparing for that, preparing for the toolkit for that. I would add as well, in terms of looking after our people, so the medical workforce team have again put on some bespoke support for our new divisional leadership teams around maybe not the intricacies of job planning, but certainly support with job planning discussions and managing medical workforce issues. So in the sort of an attempt to improve our capability, I guess, across the organisation and dealing with some of those issues within the divisions. So that work is happening. Again, they've been well received and really quite popular, so we'll continue with that. And the last thing I would add is around belonging in the NHS. So I'm sure everybody's heard of DFN Project Search. So it's something that is supported for a number of years now. We've had really good success with that programme, and as a result of that, actually our sites have been awarded a bronze award at the DFN Project Search National Conference. So that's a real achievement for all the teams that support those internships and for the support of the careers team as well. So I wanted to mention that. That's all from me. Thank you.
We'll open that to any questions on this section. Keith, do you want to kick us off?
Yeah, thank you for that. It's just one clarifying question regarding belonging in the NHS and the staff survey. It says results were released with key improvements around my team, sustained reduction in discrimination towards BAME colleagues. But then it goes on to say there was a deterioration in health and wellbeing and an increase in bullying towards BAME staff from managers and colleagues. Just seems to be conflicting a little bit.
Yeah, so the health and wellbeing is the areas we discussed at the board workshop. I don't remember that, around the stress and levels of burnout and how our staff were feeling. In terms of the experience of bullying, my understanding of that is that we've seen an improvement in terms of the results internally from managers, but we've seen a deterioration in the results from the experience of our staff from patients. So I will confirm the accuracy of that, Keith.
Great, thank you. Thank you.
Thanks, Keith. Any other questions on this section? Karen?
Oh, thank you. And to some extent, this is responding to Keith's question, and it's just really to highlight, Keith, that the People Committee, particularly with the leadership colleagues from the divisions, are absolutely keen to look inside the granular detail that reflects the summaries that you see here, because that's actually where we need to be focused and where we need to pay our attention and where we really need to understand the experiences of those people's in divisions, services and teams, and for that granular detail then to be informing the improvement plans at divisional level that then will report back up through People Committee and onto board. And you're absolutely right. Some of this data, when triangulated and then put together with some of the anecdotal and narrative feedback, sometimes does present a story that we need to unpick in order to understand and respond fully. So I would expect that you'd see more detailed responses to your question as we begin to report further assurance on our response to the staff survey.
Thank you, Karen, for that. I'm going to go with Sarah, Tony and then Mike. Sarah.
Thank you. It was actually on that question that Keith asked actually, and thinking about, so it's really good to see a reduction in bullying harassment from managers and colleagues, but obviously really disappointing to hear about that from patients and families, and I guess it probably reflects some of the wider challenges that are emerging nationally. It's not local necessarily specifically to our trust, and I think also reflects a little bit what Susie touched upon, talking about some of our data that we collect. So how are we being clear in terms of the culture that we set on our sites, about what is and isn't acceptable behaviour towards our staff, and how are we supporting staff to be able to challenge unacceptable behaviour or comments from patients or family members or others on our sites.
So we've done a lot of work around the Zero Hate campaign, starting with the policy, but also with very visible communications, and also, you know, posters and different items in patient areas. And we work very closely with the corporate nursing team and the patient experience team. But that is a difficult position for our colleagues to be in, and challenging behaviour, and particularly from certain cohorts of patients, I think, as well. So it is something that we continue to work with the teams to support with our corporate nursing colleagues about how to do that. But the Zero Hate campaign and the support of the inclusion team around that has been a main mechanism for that.
Thank you. So, and I suppose, because sometimes it might be really difficult for an individual member of staff who's been on the receiving end of a comment to do that, but I suppose the question is about how are we supporting managers or ward managers or matrons to be able to have that conversation with patients or users on behalf of their teams.
So Dan West is really engaged in the Zero Hate work, and working with the senior nurses to coach through exactly that kind of conversation and how to do that and how to have that, as well as we make sure that we've got support for colleagues who experience that either in the moment or through the professional supervision and support arrangements. So, thank you.
Tony.
Yeah, thank you, Andrew. Thanks, Rebecca. Just around appraisals, when can we expect a sustained improvement of the right numbers to be achieved?
So, as I say, we have this conversation in performance reviews, and the plan for each division is different, obviously based on the current compliance rates. So there is obviously we need the former years appraisals to be completed before the next years of appraisals are due to start. So in terms of where we are currently, I would expect that we reach the required levels late spring, is it? So June, July time, summertime, in order for us to move forward with the next year's appraisals.
So if I can come to secondary then, so just to be clear then, because I think my very first board meeting appraisals were not compliant in terms of overall quality and numbers. So are you saying that we will definitely hit a position across the trust? Is it spring and then that's sustainable from there on in terms of the performance required, or are we just playing catch up? I don't get it's not criticism. I'm just not sure if we've got a sustained approach to meaningful appraisals in the trust, because it's been running now like this for quite a while.
And you're right, Tony, it's the universal challenge, I think, in any trust really, in terms of appraisal compliance, which is why we've looked at different ways of doing this. So how do we look at more meaningful one-to-ones which support that ongoing appraisal process, rather than a once a year approach to everybody going through an appraisal at the same time. And we're looking at a similar model to how our medical colleagues do it, where do you need to be appraised by your immediate line manager, or can that look slightly different to help to achieve that target? But also we're all aware of operational pressures, and it's resulted in some decisions where managers have been deployed into clinical roles in order to deal with the acuity of patients and the operational issues that we're seeing, so that it's a perpetual conversation, and there are always multiple factors. So I think for me, it's about how do we provide the tools to support managers to do and achieve the best compliance rates that they can, alongside the new measures for quality improvement as well. I don't think there is a final answer, Tony, sorry.
And Tony, as I'm assuming it's linked, I'm going to bring in Karen and Steve. So Karen.
Thank you. No, I think absolutely great question, Tony, and one that we have also asked in People Committee. Just you'll see in my 3A's report coming up that the ask now of our divisional colleagues is to translate their commitment to improving appraisals into really clearly defined metrics, really clearly defined trajectories, and really clear evidence of progress against plan. And appraisals will absolutely squarely be in that place. And so I would anticipate that after our next people committee and the next report to board, we will be able to much more accurately respond to your question, because that's absolutely what we're looking for in the committee also.
On this point, Steve?
Well, it was, and Karen might have just said what I was about to say. You know, this is this core requirement to support staff across the organisation. So it's easy to say, but we must improve the appraisal compliance rates and for them to be meaningful. And what I was going to suggest was, Rebecca, notwithstanding what you just said about the challenges, I think the action is for you and the executive role to be able to report to the people committee what that trajectory is and what the steps and assurance are to be able to get there. So I don't think we can answer definitively, Tony or Karen, what that timeline is currently, but I think that should be a clear action. And we clearly do need to work, Scott, through divisional directors and the operational teams, so it's meaningful across the organisation. So if that's
happy, that's appropriate action. And I want to bring in now Mike and then Amin. So Mike.
Thanks, Rebecca. On page 121, Rebecca, the short-term sickness absence training, is that a piece of work that will come to an end and then we can actually measure the impact of that training, good or bad, or is it a continuous offer that's going to be always there?
So there are two elements, Mike. That there's the bespoke training that we've been doing over the last few months to really focus on bringing our absence levels down, as well as the people management development programme, which is an ongoing offer. So I expect that the former will cease once we don't have the demand for that, but the management development programme will continue as part of our core offer, really, and that's for new managers coming in or new managers moving in, new people moving into management roles, so that will stay.
So we should be able to see at some point where we can measure the impact of this training.
Yeah, I think we can see it in terms of the decline we've seen from 6.28 in November up until this point, or end of year point. I definitely think that can be related to the impact of that bespoke, well, the combination of both of those training programs. Yeah.
Thank you.
Amin.
Yeah, thanks, Chair. A question really seeking assurance regarding job planning. I guess first thing is there's a number that aren't started. So when will those start and what is the trajectory? But I guess the more important question is given how important this is to the financial objectives, one of the things that was raised in the Finance and Performance Committee and all the subsequent discussions that we've had regarding the 26-27 plans was how can we link the job planning activity where those are responsible to the financial numbers that drive that and have that better link, because at the moment it seems like we report those numbers on a monthly basis from the financial output, but maybe don't articulate how they link with that decision making. So how can we have that closer working relationship?
I'll answer that if that's okay. So there's a number of things. One, we've obviously gone into the new financial year, and so we're obviously this is yearly job planning that we're doing. There's been some that we've not commenced because they will change when we look at the theatre timetable. So there's some things around the theatre timetable that will change the job plans based on the theatre, but then the knock-on effects with things like outpatients. So we've held a few of those from a surgical point of view because of that. And then in answer to your question in terms of that kind of activity and demand, that's why we've, and it's mentioned around the team job planning. So we had a national lead and one of the regional medical directors do a presentation that's recorded, which I know a lot of our teams have joined in, and we've circulated a lot of information with our clinical leads, and it was also on our first clinical leads day, because I think as we transition from that sort of individual job planning to team job planning, that's all about looking at things like covering UEC, so urgent emergency care, then looking at our elective, how do we do that across the board? And then we've also talked about how that links in with our nurse practitioners and our allied health and nursing colleagues, and how that links in from a team point of view. So there has been improvement on the individual. There's more that we can do. We need to get the theatre timetable embedded, and then we're rolling out the team job planning this year.
Any further comments or questions on this section?
Okay, I'm not sure I'm doing a good job of keeping us to time.
That's my job.
Can we go to finance next, please, Helen?
Thank you. The Trust financial performance at the end of the financial year ending March 26 was a deficit to break-even plan of 6.1 million. That said, we had confirmation during March from the System Turnaround Director for Lancashire and South Cumbria that our revised trajectory for the year was 6.1 million deficit. This was in line with the system achieving the overall deficit of 164 million across Lancashire and South Cumbria. So we achieved our required outturn at the end of the financial year. That also supported the fact that we had enforcement undertakings on our licence, one of which was to achieve the plan set by the System Turnaround Director, and the other was to achieve an improving underlying position quarter on quarter from Q4 of 24-25, which we have also achieved. You'll see in the accounts for the year, there are some adjustments for impairments, which mean that our financial position won't be reported in the accounts as 6.1 million deficit. These are technical adjustments that happen when assets are revalued at the end of the financial year. There's also an adjustment between income and expenditure for the additional pension payments that employers have to pay at the end of each financial year. This is paid centrally by NHS England national team for some reason, and we adjust for that in the accounts on an annual basis. Just in a little bit of detail in terms of the financial performance, our agency position I report on every month is absolutely fantastic compared to the national cap of 1.9% that was applied. The trust performance was well within that cap at 1.27% at the end of March. Within that, we do still have significant agency reliance in some medical staffing areas, which colleagues are aware of through different forums, and there are action plans related to those specialties in terms of improving that. And I think we've seen a significant improvement during the year based on the successful recruitment that we've had. The deficit to plan predominantly is in relation to the waste reduction programme performance, which was around 12 million behind plan at the end of the financial year. This remains a significant challenge and focus to us going into 26-27, and we've had some external support to help us with that planning going into the new financial year. We did hold quite a significant cash balance at the end of March of 19.3 million. That's been again carefully managed as we head into the first quarter of the financial year, with the focus still remaining on us managing our smaller suppliers and local supplier payments as a priority, and obviously that we can ensure that the payroll can be met at the end of each month to pay our staff. At the end of the financial year, the capital programme was £1,000 over plan. So I class that as being very well managed with all the colleagues across the organisation. In February, I reported an underspend against the capital programme of almost £9 million. So the significant effort that was made to ensure that the CT scanner was delivered at Furness General and all the other larger expenditures that we experienced during March were delivered is to be commended. So I'd just like to put that on record for the wider team that support the capital programme. Thank you.
Any questions or comments? Chalavani.
Yeah, so Alan, just on the 19 million cash within the organization, does that pose any specific risk to the organization?
The cash that was in the bank at the end of March.
Yes.
I mean, that was 31st of March, so
Yeah.
the cash position will be different today. It's a good position to be in that we had that value. And the risk that we've got going forward is that we don't achieve some of the financial improvements to release the revenue to support the cash position.
Yeah,
Does that answer your question?
I was just thinking in terms of our position from because we were in 6 million deficit, isn't it? But we actually have 19 million cash in our bank.
Yes.
So my question is, does that pose any specific risk in terms of our financial position at end of financial year, that we've got this deficit, but we've got this 90 million cash?
No, the cash position is separate, so we will account for the income and expenditure based on the month that it relates to, but we won't necessarily pay the creditors in the month that we get the invoice. So that's often why the cash balances are slightly different. We also receive education funding in advance, so we'll receive the cash in the bank, but it's actually for future period expenditure use.
Okay, that helps. Thanks.
Well, just to briefly add to that, it's an important question, Chalavani, thank you. It reinforces to me that the challenge that we're facing this year with £30 million financial improvement programme. We must, as an organisation, take every step to ensure that we deliver within the resources that are allocated to us. And notwithstanding the success that Morecambe Bay's had in improving the financial outturn from last year, I think that just brings into really stark focus how challenging it is. So that's my first comment. Secondly, I think probably to say thank you to staff across the organisation who worked incredibly hard to deliver that improved position. It's the efforts of staff in really difficult kind of circumstances that have enabled that. Unfortunately, we need to ask colleagues to continue with every possible action to enable us to manage within the resources that we have. But then separately, we should rightly celebrate that capital programme. That's landing a jumbo jet on a pinhead, isn't it? It's to deliver a capital programme of that scale to such a tight kind of margin is really very, very positive.
Could I just add as well that the financial position is obviously subject to audit. I know Nicola, the chair of the audit committee, is not here today. I'm sure she would have raised that. I hadn't mentioned that for the minutes. Thank you.
Thank you. Any further comments or questions on this? No.
In which case, we go to the last of the domains, operation delivery. Scott.
Thank you. So I'll come in full transparency to the numbers, because the numbers are in the back. I guess I do want, not just in terms of framing, to take us back to the decisions that we made collectively over the end of Q3 into Q4. So we decided three things. We decided to keep patients and staff safe, and to prioritise our financial recovery, and to prioritise our elective delivery. And so that's not to then set a context to excuse away some of the numbers here, because some of them are not satisfactory. But it is to remind us that with eyes open, we made some risk-based decisions on performance and on access and on how we deployed our resources, including our bed base and our capacity. So again, there'll be an inevitable thirst for cause and effect action plans. But we need to think about the decisions we've made that take us to where we are. So the most obvious one's UEC. There is, you don't need to be a statistical expert to figure out that in slide 136, 137, 139, as they relate to 4-hour access, 12-hour access, and 45-minute ambulance handover. The gradient of those graphs should trouble us. So we're at the lowest level of delivery for the last 3 years on some of those graphs. And without reading out the numbers, you can see there was already a downward trend, and that deteriorated more sharply in August. The reasons for that, to re-rehearse them, we know that we've got fewer alternatives to admission than we would like to have. We've got an out-of-hours demand that's not tolerable in the long term. We've got processing issues in our emergency departments. Some of our patients stay too long, and we have a significant discharge problem. We know this to be the case. On slide 140, you'll see the not meeting criteria to reside slide that shows we've been in special cause concern for the last 10 months. We know that within that, there are nuances within that where we see the occupied bed days reducing, and yet 27% of the bed stock in February occupied by patients not meeting the criteria to reside. The green shoot of light in our urgent and emergency care data is, as ever, the 2-hour urgent community response. So you see there, having been a special cause concern for 9 months, it's back into common cause variation, but way above sustainably the 70% target. As Steve described earlier, what we will do is dust down and really now bring into one space our consolidated UEC improvement plan. We need to move beyond being right about what needs done or process measures to moving the dial on the outcome measures. So we'll bring something into execs next week. I'd expect we will then take out into the subcommittee space on what that looks like, and it will include what happens pre-hospital, what happens at the front door, what happens in the wards and departments, and what happens at the back end. It'll be a dozen actions, not 47 actions, and they'll be enumerated with owners and dates and trajectories. There is now an imperative for us to have a compelling UEC action plan that will actively invite scrutiny and challenge on, and it'll be public facing. Much more to follow on that. In cancer, you see sustained special cause concern in 28 days. We see gynae, urology and colorectal as our most challenged specialties, as is often the case. We're in the third quartile nationally for that, but we have got a good line of sight into improvements into H1 of this year, as we have in 31 days, but cautious of percentages in 31 days because the denominator is small. So you see 12 breaches of 299 patients, exclusively in breast and dermatology. Puts us in with those data in the third quartile nationally, but you'll see that improve over the course of H1. And then in 62 days, our most challenged delivery, you do see us move into common cause variation, but 10% below the national standard. And so the biggest changes we'll want to see are in breast and colorectal. But I have a level of confidence we'll start to see those cancer metrics improve over the course of H1. Diagnostics, we have a very sustained kind of steady common cause variation for years actually. We have seen a couple of spikes, one that manifests in the graph and one that will manifest last month, this month and next month, are in workforce fragility. So in the reporting period, we're 6.6% against a 5% target, driven by challenges in echocardiography, CT scanning and non-obstetric ultrasound. We had a transient deterioration up to around 14-15%, but confidence, having had the performance review with colleagues last week, that we'll see that back at sustained less than 5% over Q2 and still very comfortably in the top quartile nationally. And that includes the assumption this year that will improve elective access by 7%. So that's baked into the workforce plan, the finance plan and the access plan. In elective access, I will do the thing I normally don't do and say please move beyond the data in the pack because it's wildly out of date and take us to the confirmed position that on the 31st of March, our elective access was 71.5%, which would make us the at that point the highest performing non-specialist trust in the northwest of England. I can't emphasise enough how much work that is. It's absolutely ferocious to improve our 18-week RTT by 6% over 11 weeks is an enormous piece of work. And certainly colleagues at this side of the table will attest to sitting in this room long into the night some nights with the teams who did some incredible work here. So to deliver that level of access, which was a stretch beyond the original stretch, and having spent millions of pounds fewer again on additional activity sessions, speaks to what the trust can do in the elective space. and creates a great platform for this year, where of course this year the activity is prospectively funded. So we are funded upfront, and credit to our commissioner for that, with a 7% improvement in our access plan. So with our levels of efficiency, with our decreasing reliance on additionality, and a positive move from the commissioner to fund our plan, then we should be setting holding ourselves to what will be a really high crossbar of 78.5% by the 31st of March. 65 weeks or 4 in February, which is not okay. So we've been a special cause improvement for a very long time, but we should be having no 65-week breaches that are capacity related. So we'll be very much focusing on that, and that there'll be no tolerance for that as we move forward. Our waiting list size, so you see sustained special cause concern. The spike that you see in December 25 is because of a change in recording rules around nurse-led activity. You'll see in the data point in the chart, a waiting list size of 34,800. That's reduced by around 1,500 since then. So we are seeing a tipping in waiting list size, and to do that at the same time as improving 18 weeks is something that very few trusts can do. So we are making some progress, we believe, in the waiting list size, and that again, that's baked into our plan. Missed appointments, you'll see we're at the lowest level that we have been in several years around missed appointments. At one point, certainly remember, colleagues have been here for a bit, will remember 3-4 years ago that was a double figure number, what we called DNAs at the time. But that now being at 6% is the result of some significant work by the team and the impact of our PIFU, which we've now got in 17 out of the 27 specialties. This time last year that number was 9. So we've seen more specialties. Not only is our average going up, and we're the best in the country for PIFU, but we've also seen the numbers of specialties that embrace PIFU go up, which is noteworthy. Finally, on stroke, just please take caution with the chart, which will make sure it doesn't happen next time. So the bottom bar in the chart is unvalidated data. The messages up top on slide 153 relate to the reporting quarter and this quarter, and they are valid. So we know that FGH is at a D for stroke, which has been for 4 out of 5 quarters, and it's at the higher end of a D. We know that RLI is at an E, which has been for 2 of the last 5 quarters. The bit that's heartwarming in the text is that we've seen a marked increase in the number of patients going for thrombectomy and accessing thrombectomy. That's really positive. As colleagues will remember, that's been many, many years in the making, and we are seeing patients from all of the patch, and particularly from FGH accessing thrombectomy, which is positive. It does mention the challenges in speech and language therapy and the domains that sit behind the aggregate score for stroke. Access to therapy and access to speech and language therapy in particular are the most challenged. We've seen some, particularly with Lynn's involvement, we've seen some early strides and improvements, and indeed when we did the staff listening event a couple of weeks ago, staff were starting to feed back that they're feeling some of the changes that we've seen in speech and language therapy leadership. So we're hopeful of some, and including recruitment and colleagues returning back to work. So we're hopeful that will start to move the dial in some of the stroke metrics as well as more generally. Thank you.
Great. Any questions or comments for Scott? Awesome.
Thank you. Thanks, Scott. With the waiting list over 52 weeks, do we understand why the position, you probably do, why the position has deteriorated so much? And also, do we know the proportion of patient choice versus operational pressures for the increase?
The second part we will, I don't have those to hand, but we will. I'd expect a lot of the 52-week will be patient choice. I'd expect more of it will be capacity, but I can confirm that offline. Without deferring to too much of a technical answer, waiting list management is genuinely that piece of hitting one lump in the carpet and it moves somewhere else. So focusing on the front end of the 18 weeks, while at the same time trying to judiciously reduce waiting list size, means that the tail end, 52, the tail end of the waiting list is the one that you pay the least attention to, in the same way as tail gunning. The back end of the waiting list means that your 18-week performance suffers. And so that stands as a general principle of waiting list management, having sat with the numbers and been walked through them by our experts, we can point to that. So it's a vagary of the way we've managed the 18 weeks and the waiting list size. But clearly it would not be okay for us to have 570 52-week waits. So we now need to, in the front end of the year, make an impact on that and not let it get out of control.
Because just looking at the graph without the nuances, you think, goodness, in 2024 to 25, cracking, we were coming down, 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 and then during 2025 until now, we've gone up, 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 up.
Yeah. So two things, and again, it comes to a risk appetite, doesn't it? So two things. The much of the improvements that were made historically in waiting list, particularly long waiting lists here, were built almost singularly on additionality waiting list initiatives. And so in that really fine kind of narrow bandwidth of trying to improve our own efficiency, reduce our reliance on additionality, and it will be no accident that the top specialty in terms of 52 weeks is trauma and orthopedics, where there was a significant reliance on additionality and waiting list initiatives. So it's in that space of not wishing to keep deploying additionality, but at the same time not letting that get out of control.
Thank you.
Thanks. Keith.
Yeah, thank you, Chair. Yeah, thank you, Scott. It's just a quick question, really, and it's around the ambulance handover times and the delays that we're seeing. Are we seeing that impact on response times in the community? Because there must be some sort of give somewhere, and I'm wondering where that's occurring.
Yeah, that's a good question. Thanks, Keith. So without wishing to speak for NWAS, because that would be wrong, my view is not. So if we look back serially at the last 3 years, the category 2 response time in this geography has improved each year. So although we would want to hold the discomfort of that graph that shows the 45-minute turnaround time, this winter compared to previous, we've seen category 2 performance improve rather than worsen. So that would give us a confidence that the population is not being starved of access to category 2 ambulances.
Right, thanks, Scott.
Thanks. Mike?
Thanks, Andrew. Thanks, Scott. Slide 151, Scott, the missed appointments, diabetic medicine at 21%. Do we understand why that's so high? Because I'm assuming if that condition deteriorates quickly, then they'll arrive at ED quite quickly as well.
So I might defer to my colleagues to my right, but certainly I would expect in 3/4 of trusts that diabetes, orthotics would be, and physio would be the top 3 sometimes, because it tends to be a different patient choice about when they come back or not, and it's usually not for a binary episode. It's for ongoing care. But if my clinical colleagues to my right have got anything to add, then so yeah, I think it's more diabetes is often for life, isn't it? So the patients may make different choices around attending fixed appointments or not.
Okay, thank you.
Thanks. Karen?
Oh, thank you. And thank you, Scott. Just 3 separate questions, all about AHPs. Just looking at the not meeting criteria to reside, or as you know, I prefer to think about this as people stranded in our care. I can see that really significant shift to AHP leadership around those reviews, around risk tolerance and gaps and so on. Are those actions also accompanied somewhere else? Wouldn't expect to see them on the IPR. Are they accompanied by improvement trajectories so that we really understand the difference that AHP leadership and input is making to thinking and action and discharge patterns? Is it matched with an assurance trajectory?
the improvement trajectory is really about the number of patients awaiting therapy input. So we've got, I think it's 5, isn't it, on the waiting list. So we did start off at quite high figures. So we're getting those patients reviewed much more quickly. I think you're asking quite a complex question that I might need to go and look in a bit more detail.
Yeah. Okay. And happy to unpick that a little bit more. I think it'd be really helpful to understand that. Brilliant. Thank you, Lynn. My other question is around speech and language therapy, and absolutely understand the recruitment challenges there. The first one is, might there potentially be any system level solutions to recruiting speech and language therapists? Just conscious that the two universities that we work most closely with don't train speech and language therapists, but others do. So are there any system level solutions to explore, or are we exploring them? And the second one is, how are we managing the risk around not having enough potentially speech and language therapists in the stroke space?
So I can speak to one of them because I chair the stroke network for LSC. So we've just had the funding, so I've just received it, that we've had the funding extended until July of, I think it's next year, around NROL, which is the remote access to therapy, so we can see how many hours of therapy, and that was really important because that was actually allowing us to deliver a significant amount of therapy in a remote way, which is obviously all the things we should be doing, community, left shift, etc. So there is that. We're also just looking at, as part of, I'm also on the stroke workforce group and for the region, and we're just looking at non-medical consultants, and that's not just nursing, it's also thinking about allied health. So there's a presentation around that pathway and what we need to be thinking about strategically, which is going to be coming to the CNO joint meeting for LSC. So quite a significant amount of work is happening in the sort of stroke workforce side of things in a really coordinated, interdisciplinary way.
Oh, thank you. That's really, sorry, if I may just briefly, my understanding is that I absolutely understand we have some recruitment challenges specifically related to speech and language therapy. I'm not sure that they're reflected by our other organisations in the system. So I'm wondering what it is about our trust that is not so attractive to those workforces, and how might we understand it, and what might be a system solution. Not a response for today, but potentially something to think about.
Yeah, to take that away, Karen, one of the things that we're particularly looking at is sort of better access to equipment like video fluoroscopy.
Absolutely.
So we were discussing it yesterday, Capital Steering Group, so that's an absolute priority. So if you've got the right sort of service, you can attract the staff.
Yeah, absolutely. And as ever, happy to support if that's helpful as that work goes forward.
Thank you.
Thank you.
Sorry, just briefly comment, Karen, on the point you made about local university provision of speech and language therapy. I wasn't aware that if that is a gap from our local university partners, if it is, we can't resolve that today, but certainly that feels an important conversation for us to be having as an organisation with our education sector partners about what else can be done to help us address where we do have recruitment challenges. So those educational, academic and research relationships are really important, and happy that I've just looked at executive colleagues, we can take that as a action or consideration.
Yeah.
Sarah. Thank you. I'm conscious of time, so I think I won't labour this point. I was looking at the not meeting criteria to reside slide, which is page 140, and just sort of takes you back to the discussion we had when we were discussing whether or not we could support the closure of beds, which was partly based on the downward trajectory, sustainable downward trajectory in the number of who are stranded in our care. And noting it's gone up again. Obviously, I recognise that's partly because of the time of year, But I think what still is missing for me, and I know it's picked up at the Transformation and Improvement Board, but it's understanding in this IPR and in this chart or the narrative, how many of these are within our gift as a trust again? And I know we've talked about this quite a lot, but I think that would help us understand a bit more meaningfully, even on the times we receive the support, where we're going, what the direction of travel is.
So Emma Rainish has just done a really good piece of work at both Lancaster and Furness, and she's written a review which absolutely pinpoints where the cohorts of patients and what is within our control, what is around commissioning or non-commissioned capacity, and we've already started to have those conversations, but we've started certainly from the Cumbria Place-based partnership. They've started to have those discussions with the ICB about commissioning more intermediate care, so that's been really positive this last week. What the other thing I was going to say, but that paper is there, and it's really stark, isn't it, about where we need to focus our attention.
And so is the assurance around that, is that through Transformation and Improvement? I know Tony's got his hand up actually, but it's, yeah.
Tony?
The answer is yes, but also as part of it, we've agreed that we'll bring it back to, and it keeps getting knocked back, but we're going to have to do it, bringing it back to a wider board conversation for the reasons you've said and articulated, because it is so complex. It's commented upon in the 3A's report, and I think a wider board discussion, and importantly, a joined up strategic approach around this, because it's not just about people who are currently locked within their hospital. It's about the front door. It's about the flows out of the hospital. It's about the processes and systems within the hospital, and about a wider system approach. And the commissioners are key to some of this as well. I'll touch upon that in the 3A's report, but you're absolutely right, Sarah.
Thank you, Tony. If there are no further comments on the IPR, I am going to suspend the meeting now for a lunch break until 1:30. The meeting will reconvene at 1:30. Thank you all. See you soon.